अस्सलाम वालेकुम। कैसे हैं आप लोग? उम्मीद है ठीक होंगे। आई एम डॉक्टर मोहम्मद अली रबानी, असिस्टेंट प्रोफेसर एनाटमी, और today we are going to continue with our fifth lecture of this series of lectures on the gross anatomy of head and neck. Today we are going to discuss face, scalp, temporomandibular joint, and the related regions. So the topics that we are going to discuss is face, all the muscles, the arteries, veins, and everything that is related to the face. Scalp, the area that is on the top of your head. Temporomandibular joint, the joint itself, the articular surfaces, the muscles that are creating the movements, and some clinicals like the dislocation of the joint. Parotid regions, the region right here where you have parotid gland, what it is covering, what are its walls, relations, and the contents. Then temporal fossa, this area right here. In Urdu, we use the word kanpati. This area, temporal fossa. Then infratemporal fossa, the area that is behind the jaw. By behind, I mean that is deep to the jaw, that is deep to the ramus of the mandible. And then pterygopalatine fossa. All of these structures we will be discussing how these structures are formed, their boundaries, their relations, and their contents, and we will dive into the depth of some of the contents as we go along. I know this is a heavy topic, but inshallah, we will take it step by step. We will build from ground up, and by the magic of technology, you can always listen to this lecture again on the YouTube. And if any query remains, if something is there that you want to ask, please do mention in the comments. We will try our best to answer this query. Let's talk about the face. Overall, the skin is covering the face. It is very thickness. It may be thick like that on forehead. It will be very thin like those on the top of the lips or the eyelids. It has a number of sweat and sebaceous glands that leads to sweating and the oily nature of the face when there is hot temperatures. The thing that separates the skin of face from rest of the body is that it does not have any deep fascia. There are a lot of muscles that are getting inserted to the inside of the face that gives rise to the make possible the facial expressions, and that also makes possible the wrinkles. So usually the wrinkles that are created in the face are about 90 degrees to the muscle direction. For example, front occipitalis, the frontal valley comes like this. From up downwards, when it contracts, you get these frowning wrinkles. And here are the orbicularis oris muscle. As you grow old, there are crow foot wrinkles, and so on. So these are due to the muscles, and that's why the Botox injections works. You actually paralyze those muscles. Those who are creating the wrinkles, they get paralyzed. Apart from that, the things that you may notice on the face is basically the hairline. The hairline. This hairline, not a definite anatomical landmark. It may have a variable location in a different individual, and that defines the upper extent of the skin. Lower extent, it is defined by this jawline. Then we have forehead. Forehead is included in both the face and the scalp. The forehead region up to the eyebrows, it is included in the scalp region, and up to the region of hairline, or where the hairline should be, is also included in the face region. We have eyebrows, nose, nostrils, eye, medial angle, lateral angle, also known as canthi, this vertical lip. Alhamdulillah. Excuse me. So this vertical groove that is in middle of the upper lip, that is the philtrum. The lips, the part that is reddish, the very thin part of the lip on which we put on the lipsticks, that is the vermilion border, and that's what it. We will go into the detail of the things as we move along. Okay, let's start with the muscles of the face. Face has a lot of muscles. Let me shift to the 3D model. Face has a large group of muscles. There is a lot of muscles, and you will see that apart from general arrangement of the muscles, they are muscles that are surrounding the orifices. You will see the muscles surrounding the orbit. You will see the muscles surrounding the oral cavity, and there are other muscles also. Let's work our way from top to bottom. The first muscle that we see here on the top, this is known as frontalis muscle. Frontalis muscle, this is basically a part of a muscle that has two bellies. Fronto-occipitalis muscle, it is a frontal belly right here and occipital belly right here on the back. On the back, it is attached to the superior knuckle line, supreme or highest knuckle line. Then on the scalp, it has aponeurosis that is seen right here. And on the front, there is again fleshy belly that is attached to the eyebrows here. So when it contracts, it brings your eyebrows up. And as it brings the eyebrows up, you can see the horizontal wrinkles on your head form. So it is attached. I will show on the lateral view the like this. In the back, it is attached to the highest knuckle line. This belly is the occipital belly, and it has a aponeurosis. This aponeurosis is lying on the top of a loose connective tissue that helps the sliding of this aponeurosis. And in the front, it is attached somewhat to the superciliary arches, but mostly it is attached to the eyebrows. So this is the frontal occipitalis muscle. Then let's look at the muscles that are surrounding the eye. The eye has an orbit, and a sling of muscles goes around it that is known as orbicularis oculi. Orbicularis oculi. It has two parts. The part that is outside above the bone, above the bony margin, and the part that is on the inner circle that is in the eyelid. So let's talk about this. This is the palpebral part because it is present in the eyelid, that is known as palpebra. This white structure that you are seeing, that is known as medial palpebral ligament, and on the left, you will, it is not very visible here, it is embedded inside a right greenish structure. You may see blinking right there or right there. This is the lateral palpebral ligament. So this muscle, the palpebral part of orbicularis oculi, it starts from the medial palpebral ligament, goes all the way over the eyelid, and inserts on the lateral palpebral ligament. The same goes for the palpebral part of the lower lid. It helps you in blinking of eye when you are doing it calmly, when you are doing it without forceful, like this. If you can see through my glasses, this is the function of palpebral part of orbicularis oris. This is the outer part. This is attached to the parts of the bones that are making the margin. It is attached to the nasal part of the frontal bone, the frontal process of maxilla, the medial palpebral ligament. Majorly, it is attached to this medial aspect, the frontal bone, the maxillary bone, the medial palpebral ligament, and then it circles around the eye, and it uh, makes a complete circle. So this is the muscle that gives you a forceful contraction. Okay, let me compare you both the functions. If I am contracting only the palpebral part, if this is the function of the palpebral part. If I've contracted forcefully, like I'm protecting myself from shampoo going in my eyes, so like this wrinkle form, this forceful form, that cannot be opened. This is made by orbicularis part. This function is done by orbital part of the orbicularis oculi. So this is about orbicularis oculi. Then there is this muscle that is present just above the orbit. If you do the dissection and if you remove the skin, you are not able to see this muscle. On the upper aspect, you will see fronton. On the lower aspect, you will see orbicularis oculi. But behind this muscle, if you dissect through this muscle, you will see this particular muscle. This is called corrugator supercilii. This particular muscle is called corrugator supercilii. It is attached to the superciliary arches we discussed in our first lecture, and it is coming to the skin just above the bridge of the nose. So when it contracts, it brings both of your eyebrows together. When you do this wrinkle, this vertical wrinkle that is formed, that is due to the corrugator supercilii. It brings both of the eyebrows together, and um, the better word would be, let me show you. It's a one interesting picture. I will be moving back and from this one. This is from the Grant Settlers, and it is in the uh, Grant Settlers, the book that is Keith Moore. So here you can see the function. This vertical folding, nearing of the eyebrows, this is due to the corrugator supercilii. This raising of the eyebrows with foldings, it's due to the occipiter frontalis, and these are the function of the orbicularis oculi. So let's move on to the next muscles. Let me get one thing straight. Okay, let's talk about the muscles that are surrounding the nose. There's also a depressor supercilii that helps in the depression of the eyebrows on the medial aspect of the eyebrows. But let's talk about it later. Let's. There are a lot of small muscles. We may not be talking about all of them. Let me get myself back. Okay. So here is this muscle. This is known as procerus. It brings the skin fold down. It brings the skin fold down. So when you are going, what's the word for that? In Urdu we say tashwish, colors. Um, when you are showing a concern, you do like this. And so the eyebrows are coming together due to corrugator supercilii, and procerus is making this end down also. So it depresses the medial angle of the eyebrows and wrinkles the skin over the bridge of the nose, where is seen here. It is shown this horizontal wrinkles on this part of the nose. It's due to the procerus. Okay, let's move. Then talk about the nose. There are some muscles that are involved in the depression of the nose and closing of the nasal opening, and there are some that are involved in the opening of the nasal cavity. So there is this muscle. This is simply known as transnasalis muscle or transverse part of nasalis muscle. It is attached to the maxillary bone right here, and it comes over the bridge of the nose, and it ends by inserting into the counterpart muscle from the opposite side, and they both come and they function. Their function is to compress the nostrils, compress the opening of the nostrils. Then if we have to compress, there will be something that will be able to open it up. That is this muscle. This part of the nose, that is called the ala. So this is the muscle that is attached to the maxillary bone right here, and it is attached to the skin of the ala, and it is the one that helps in opening and dilating the nostrils. Humans can do it, but it's not very prominent. It's very prominent in the bovine animals. The other animals, it is very prominent. And then there comes this muscle, a very small muscle, depressor septi nasi. So it basically depresses the nasal septum and downwards pulling of the nasal septum. So these are the muscles of the nose. The muscles that are related to the nose procerus, bringing the forehead muscles down and wrinkling horizontally and bringing the medial end of eyebrows down. Then there was this transverse part, this part of nasalis muscle, and this is the dilator part, alar part of the nasalis muscle. So in some books you may read about the nasalis muscle only and dilator nasi and compressor nasi and dilator nasi. These are the names of the same muscles depending upon their functions. Okay, let's move around to the orbit. Sorry, oral cavity. Oral cavity consists of a ring of muscle that closes the oral cavity. You may have guessed its name by now. You might already know it. That is known as orbicularis oris. It is forming an orbit. It is forming an orbit around the oral cavity, orbicularis oris. It has a part that is present in the lip, and it has a part that is present beyond the lip onto the surrounding bones, that is the maxilla above and the mandible below. So it has this. It simply helps in closing the mouth. When you are doing very light contraction, simply closing the mouth. When all of this muscle is contracting very forcefully, you make a circle and push the lip out. That is pouting, we see in the social media language. So this is the function of the orbicularis oris. So it has, just like the orbital part, it has the part that is in the labia, in the lip, and it is the part that is present outside. Both of them are helping in compression of the lip, and as meanwhile protrusion pushing it forward. Then there comes this muscle. This is then, if you have to close your mouth, you also have to open your mouth. So the opening of the mouth, it has like the mouth in the center, and radially, like the radius of a circle, it's a large number of muscles that are having its radial attachments, that are having its, that are pulling it in each direction. There is a lot of muscles that are pulling it downwards, medially, towards this angle, towards midline, away from the midline. So these are the dilator muscles. Let's dive into them one by one. First, we'll start our discussion with the ones that are on the superior aspect, that will pull the upper lip up, that are basically levator labii superioris, that will pull the lip up. So the levator labii superioris, this is the one that is levator labii superioris. It originates just below the margin of the eye, just below the margin of the eye, and inserts into this part of the lip. It simply pulls the lip up. It pulls the lip up, and this is levator labii superioris. Then there is this levator labii alignesi. Levator labii superioris alignesi. It is coming from the nasal aspect of the medial. It is coming from the nasal aspect of the maxilla, frontal process of the maxilla. It is attaching somewhat to the ala of the nose, and it's inserting into the lip. So it is elevating the upper lip also, as well as dilating the nose. Then there comes this muscle, the third levator. There are three levators. We talked about levator labii superioris, and then we saw levator labii alignesi, and then the third one that we have to discuss is this one. This one. This is now a levator angulioris, that raises the angle of the mouth. The crooked smile. I am not able to do it very much accurately like that, but there are some people who can just, they can raise their part of the lip like the hook in the upper lip. So let me get back to that picture. He has done a very nice job. Okay, first let's cover the muscles on the superior aspect, then we'll move to them. We're only left with two muscles, the three levator muscles. We talked about levator labii superioris, levator labii angulioris, levator labii alignesi. And then there is this muscle. Okay, these muscles that are shown right here, There are two muscles that are coming from the zygomaticus bone. Um, that is located by anguli oris, that is zygomaticus. That is zygomaticus major, and just near it you will be able to see a very small muscle, zygomaticus major, and just lateral to it the small muscle that is called zygomaticus minor. They are coming from the cheekbone, zygomaticus itself, and the other one is coming from the this. So this particular drawing has merged the both of them, but in Gray's Atlas, in other books, you may be able to see both of them separately. So zygomaticus major and minor are shown right here. The lateral one that is near the zygomaticotemporal suture, that is the zygomaticus minor, and the medial one that is medial to it, that is zygomatical minor. In the 3D model right I'm using right now, they have not shown them as separate muscles, so no worry about it. And then we are done with this, left with risorius. This is the muscle that is arised, that pulls the lip laterally. So all of them above pull the tongue, pull the lip up, and the risorius pull the lip laterally. So let's look here. Okay, so this is the muscles. This is for the muscles that are attaching to the angle, zygomaticus major and minor. They are attaching right here. They are attaching just medial to the angle of the mouth, like here. So they pull the lip up, like there is a hook, fish hook in the lip. Risorius, it simply pulls the lateral edge laterally, like don't go up, don't go down. Try to place it as horizontally as you can. Then there is levator levi superioris, inferioris done together, and then we'll discuss the other ones as we go through them. So we are left with depressors. Then there is this muscle that is rising from the just chin, this part, that is known as mentalis muscle. It depresses the lip. Then there are two depressor levi muscles that are arising from this area of the mandible, anterior surface of the mandible. The one that is going to the lower lip, the middle of the lower lip, that is called depressor levi inferioris, and the one that is going to the angle of the mouth, that is called depressor anguli oris. So these, their function can be seen right here. Let's move that back to that picture. So in this, depressor levi inferioris has pulled the lip down, and the risorius has pulled the angles sideways. When you're brushing your teeth and showing someone your teeth, you're making use of levator levis and the depressor levis. You're elevating your lip up and you're depressing your lip down. And in this one, only the lower lips depressors have pulled the lower lip down, and the risorius has done this. Orbicularis oris, pouting the mouth. Only depressor anguli oris, sad face. Mentalis, it pulls the lip down, but at the same time it protrudes a little bit also. So, so a sad face are mostly due to the depressor muscles. The elevation is due to the levator muscles mostly. And then there is platysma. It pulls the whole of the skin of the neck along with the angle of the mouth. So this is platysma. So this is all about the muscles that are present on the anterior aspect of the face. So let me get myself the set of muscles for the lateral view. Okay, we are done with most of the muscles. On the lateral view, you don't see much different, just a number of three muscles that you may be able to see, that will be in front, above, behind, and in front of the ear. Those are known as preauricular muscles. They're not shown very right here. Let's go to shift to the this picture, this picture. So these are the three set of muscles that are present in front, above, and behind. These are known as anterior auricular, superior auricular, and posterior auricular group of muscles. So these are all the muscles that we discussed. You might take a screenshot for this further revision. Otherwise, if you want to follow it, it's from the Gray's Anatomy. The Atlas of Anatomy is a separate book, and we have taken this particular picture For the origin insertion, this table is from the Snell's clinical anatomy by regions. So this is all we have talked about. And the innervation, it's very simple. There is only one nerve that is supplying the muscles of the face, and that is called the facial nerve. Okay, we are left with one muscle that I did not discuss in the this region. This is the buccinator muscle. Let me first make a little adjustment. We'll look at the buccinator muscle. Its origin insertion is a little tricky, that is to be discussed. Okay, that is the muscle of the cheek, the muscle that we can see right here. This one. This is the buccinator muscle. This is the muscle of the cheek. When you blow your cheek, and if you want to make the pressure inside, you use the buccinator muscle. It presses it inside. It is not only useful in blowing off a trumpet and blowing off a flute, it's a very important muscle when it comes to mastication. When you're chewing the food goes beyond your teeth, beyond between the teeth and the cheek. That's known as the vestibule, and this is the muscle that has to bring them back. If we look at the origin insertion, so its origin insertion is a little tricky. It's superiorly, it has attached to the pterygomandibular pterygomaxillary raphe. You can see its one end is attached to here. The it is one end is attached here to the humulus, to the pterygoid plate, the medial pterygoid plate. The other end is attached to here to the maxilla. So this point, this line, this line that is known as pterygomaxillary raphe. It is attached to pterygomaxillary raphe, and if you follow back, it attach, come down with the to the mandible. So here it is attachment is from the pterygoid plate all the way down to the mandible. So this is known as pterygomandibular raphe. So you will read two names: the pterygomaxillary raphe from this point to this point, and pterygomandibular raphe from this point to this point. And these are providing the origin of the buccinator muscles. And from this point, the buccinator moves front. It moves in front. It goes all the way front, covering the molar teeth, covering the premolar teeth, and it ends in the skin of the cheeks. It ends into the modulus, angle of the mouth. It merges with the orbicularis oris muscles. So this is the or buccinator muscle, and they have done a wonderful job in describing the direction of fibers. You see, the fibers that are on the top, they move top. The fibers that are on the bottom, they move to the bottom. But the fibers that are middle, they cross each other. The upper middle one goes to down middle, and the lower middle one goes to the up middle. So this is the crossing of fibers, and this is the point where you have angle of your mouth. There is a knot of muscles, and here is the point where all of the anguli muscles are inserted: depressor, levator, soleus, anguli. So these are the muscles that are inserting right here. So this is what the buccinator muscle. Let me get back to the picture. This is a picture from last clinical anatomy. So you're seeing from this picture, you're seeing the person from the left side, and you can see this attachment line. This is attached to the maxilla to mandible, maxilla to medial pterygoid plate, pterygoid humulus. That is the pterygomaxillary ligament, and below this raphe continues down to attach to the mandible. These refs becomes important because they have relation to the other muscles from this point. Just above this pterygomaxillary ligament, there is a space from which the tendons exit and come out of the space beyond it. And the thing that is important one that is moving right here, that is the tensor villi palatini, the tendon that tenses the palate. We will discuss when we'll discuss the oral cavity and the palate. And here also the palatine branches, they have climbed up from the outside, then they jump over this raphe to go inside of the oral cavity. And the second thing is about the pterygomandibular raphe, the one that is going from pterygoid plate to mandible. It is giving origin to the superior constrictor muscle, You don't have to understand the superior constrictor muscle right now. We will have a separate session for the pharynx. But the point is, this is the line. You must understand this pterygomandibular raphe now, so that you can make an understanding about the superior constrictor muscle that is going back. And here it is buccinator muscle of the right side is shown from the interior aspect. The cameraman is standing inside the mouth, and it's the camera is pointing towards the right ramus of the mandible from inner aspect. And here you can see the pterygomandibular raphe. It's coming down and inserting just behind and beyond the last molar, the wisdom tooth. And here then other MCQ point comes, that here the mylohyoid line is starting. This is the mylohyoid line. Here is the mylohyoid line giving origin to the mylohyoid muscle. And here is the pterygomaxillary line that is inserting here, pterygomandibular raphe, sorry, that is inserting here. And this is the space between the two. This space becomes very important, especially if you're in dental practice, because that is where the lingual nerve that is ultimately going to supply the tongue. It is moving between the two muscle origin insertions, and it is moving from here to the inside of the mouth to the oral aspect of the mylohyoid muscle to go to reach the tongue. So this is about the buccinator muscle, and the buccinator muscle is also supplied with facial nerve. There is also a sensory nerve that is by the name of buccal nerve. So don't, it is a very interesting question and a favorite question of the examiners to confuse the students, that buccal nerve, the name matches to the buccinator nerve muscle. Buccal nerve is sensory. Buccal nerve, it is the one that supplies the skin over the buccal cavity, that supplies the skin. It is not motor. So the motor supply is coming from the facial nerve. So this is all about the muscles of the face, their functions and their roles. And one more thing I wanted to discuss about buccinator is this structure. This is the duct of the parotid gland, the parotid duct of Stenson, that reaches the inside of the mouth by going through the buccinator muscle. That is another important question, that it gains access to the inside of the mouth by going through the buccinator muscle. So we have talked about the buccinator muscles, the parotid duct of Stenson, the pterygomandibular raphe, the attachment, all of this whole thing inside. I know this picture is showing you a lot of things, but I want you to concentrate only on the nerve aspect of the this picture. Here, all of the muscles of the face are being supplied to the facial nerve. The facial nerve is exiting the base of the skull by stylomastoid foramen. We will revise the nerves again in the cranial nerves portion. And here it is coming out. It enters the substance of the parotid gland. It enters the substance of the parotid gland. And beneath the parotid gland, it divides and joins and redivides to form a plexus of nerves that is known as pes and serinus. The same word, the pes and serinus, is used in the lower limb, if you remember, for the insertion of three muscles on the medial aspect of the tibia, the gracilis, the semitendinosus, and which was the third one? Sartorius. So these three muscles, that is the same word that is used for the nerve plexus for the facial nerves, pes and serinus right here. Here, the facial nerve exits the parotid gland from the anterior margin, basically from its superior aspect, middle, and inferior aspects by dividing into 5 branches. The one that is going to the temple region, that is known as temporal branch, then there is zygomatic branch, then there is buccal branch, then there is mandibular branch, and cervical branch. Let's go through this picture for the Netter's atlas. So here you can see the muscles, the it's more of a schematic diagram. The temporal branch going upwards, it supplies the area above the eye. It is majorly supplying the anterior auricular muscles, the superior auricular muscles, the frontal barrier of the frontotemporalis, corrugator supercilii, and some of the fibers of orbicularis oculi. And if it does not work, if it is damaged, let's say in the fracture of the zygomatic arch, it leads to person being unable to do frowning, the wrinkling of the forehead. Then there is zygomatic branch. It is majorly going around the muscles of the eye, and then there is buccal branch that is going around the muscles of the mouth. Then there is a mandibular marginal branch that is running all the way near the angle. It will be supplying some of the depressor muscles, and then there is cervical branch that will go down in the neck and it will supply platysma. The exact muscle which they supply is not very well defined, and you will see a little differences between the anatomy books. So don't get yourself very hungover on that. Just you should remember what are the five branches. You should remember what is their arrangement from top to bottom. And what happens when the facial nerve is damaged? From the upper aspect, wrinkling goes. When it goes to the eye, the zygomatic branch or the temporal fibers they die, they are not functioning. Then blinking goes, and this is the most catastrophic one. When the blinking goes, the conjunctiva dries up, the scarring starts, and it will severely affect the vision. Then the buccal branches, zygomatic branches supplying the mouth, they are affected. Then there is a deviation of the angle of the mouth. The healthy side pulls, this is the healthy side. The healthy side pulls the lip towards itself, and this fold, nasolabial fold between the nose and the lip. This nasolabial fold, it disappears because all of these muscles are not functioning. And so these are the motor supply of the nerve face. Let's discuss the sensory supply. The whole of the sensory supply of the face is from the trigeminal nerve. Trigeminal nerve has three divisions, sometimes called branches, that are the ophthalmic nerve, maxillary nerve, and mandibular nerve. So these are the ophthalmic, maxillary, and mandibular divisions of the trigeminal nerve. All three of them, all three of them have a very important role in supplying the skin of the face. The demarcating line between these three nerves are the angles, the lateral angle of the eye, the angle of the mouth. Everything above the angle of the eye, it is by ophthalmic nerve. This includes the upper eyelid and above. Everything below the angle of the eye and above the angle of the mouth. So it will include below the including lower lip and including lower eyelid and including upper lip. And below the lower lip, it will include the mandibular nerve. And if you follow the in the front, it is very simple. You just follow the eye and the mouth. But if you go to the back, they turn upwards. Just follow your, just make the three fingers, go back and follow your mandible. Follow your mandible. If it turns like this with the mandible, so it turns like this with the mandible, where it is here, right here, it turns with it to the mandible. So the back in front of the ear, it's supplied by the mandibular whole of the mandible, and in front there is maxillary, and on front there is ophthalmic branch. So what are the nerves from each of these divisions that supply this area? These are pictures from all of these, my three of my favorite books. This is from Gray's Atlas, this is from Netter's, and this is from Snell's Anatomy. So let's discuss the five nerves that are supplying the, coming from the ophthalmic division of the trigeminal nerve. So there are three nerves, 1, 2, and 3. 1, 2, and 3. Third one is not very well shown here. Yes, it is shown right here. We will focus here. So these three nerves, let me show you here. So this is picture from Netter. What are the three nerves that are exiting from the upper eyelid? The one that is most medial, just above the medial angle of the orbit, that is called the supratrochlear nerve. This one, supratrochlear nerve, it is coming from the most medial aspect of the supraorbital margin. Why it's called supratrochlear nerve? Because it's a trochlea inside that helps in the curving of the superior oblique muscle. We will go into the detail when we'll discuss the orbital cavity. So this is the supraorbital. This is the one that is near the midline. Its supply usually ends near the hairline or a little above it. The one that is lateral to it, 1/3 of the way lateral to the medial angle. And here, if you palpate yourself, you may be able to find this notch. I am able to palpate on myself. This is the supraorbital notch. In some people, the notch is found. In some people, a foramen is found. There, the nerve that is exiting is called supraorbital nerve. It is coming out from the supraorbital part, supraorbital notch and foramen. So it is just lateral to the supratrochlear, and it is the one, the larger one. It goes further beyond the midline, further beyond the hairline. It goes almost up to the vertex. Then here a little nerve is shown right here. This is called the lacrimal nerve. Lacrimal nerve is the one that is supplying the lacrimal gland on the lateral aspect of the eyelid, and it is the nerve that is supplying the lacrimal gland and the eyelid beyond it. So we have done three nerves. All of three of them are on the medial, middle, and lateral aspect of the upper eyelid. Then we are left with two. The two, that is infratrochlear nerve. Just like that, there was a nerve exiting the medial angle above the trochlea. There is a nerve that is exiting the medial end below the trochlea. That is called infratrochlear nerve. And then there is external nasal branch of anterior ethmoidal nerve. It has a very long route that is we will discuss in the with the cranial nerves, and we will discuss it partially in the nose. So these are the branches of the facial nerve. All of these are ultimately branches of ophthalmic division, supraorbital and supratrochlear. These are coming from the frontal branch of supraophthalmic division. The lacrimal nerve is a direct branch of ophthalmic division. And infratrochlear and anterior nasal branch of anterior ethmoidal, they are ultimately coming from nasociliary. These are coming from nasociliary nerves. So this is all about the nerves on the nerves that are exiting the orbit, and they're coming from the ophthalmic division of trigeminal nerve. Then we see the three nerves that is coming and that are coming from the maxillary nerve. Let me get back to you on this. This is the maxillary nerve shown in the orange. This nerve is present in the middle cranial fossa. It exits into pterygopalatine fossa through foramen rotundum and inferior orbital fissure. It comes to lie in the orbit, and it gives rise to a main branch that is known as zygomatic branch. And zygomatic branch gives rise to two branches: zygomaticofacial, zygomaticotemporal. As you can see from the name, zygomaticofacial comes from the anterior aspect of the face to the front of the cheek, and zygomaticotemporal goes behind to the back, and it opens into this temporal fossa. And we are left with infraorbital nerve. It runs on the floor of the orbit, goes through the infraorbital canal, comes out to the infraorbital foramen, and it comes to the front of the cheek, and it is the nerve that supplies the whole of the front of the cheek from the lower eyelid to the upper lip. So this is the infraorbital nerve. Let me get one thing. Okay, we are back. So this is the infraorbital nerve, and these are the three divisions, and it can be seen. This is the zygomaticotemporal exiting from the temporal fossa, zygomaticofacial coming from the front of the cheek, and infraorbital nerve coming from back. Yes, here is the one thing that I did not discuss in the face. The origin of the infraorbital nerve. Here we talked about the two labii muscles, levator levator labii superioris, and levator labii angulioris. If I remove this muscle, or if I even fade this muscle, you can see the infraorbital foramen is just under the cover of this levator labii superioris. So here an MCQ comes. The infraorbital nerve is actually running between these two muscles. It is running in front of this muscle, levator angulioris. It is running behind this muscle, levator labii superioris. So this is about the muscles of the face and their nerve supply. We have talked about the ophthalmic division. We have talked about the maxillary division. We are left with one nerve, that is the mandibular division of the trigeminal nerve. And mandibular division of the trigeminal nerve, here it shows you three nerves that comes to the surface. The one is this, the auriculotemporal nerve. It is running with the posterior to the superficial temporal nerve in front of the ear all the way to the temporal region. Then there is this nerve, buccal nerve. It, as the name indicates, it is on the buccal aspect of your face. It is just above the buccinator muscle. It supplies the skin over it and the mucosa under it. And then there is this nerve, the mental nerve, that is coming from the mental foramen. Here we discussed about the mental foramen during our osteology component, and here it supplies the skin over the cheek and the lower lip and the neighboring areas. So this is all of the supply of the face with the trigeminal nerve divisions. And there is one thing that is left, that is this nerve, that is the greater auricular nerve. We discussed that in the lectures before and in the cervical plexus, and this is the one that is supplying the skin over the angle of the jaw. This is the one that is supplying the skin over the angle of the jaw. So this is greater auricular nerve. So here is the picture for you. I'm not going into the discussion right here, but you can identify which nerve supplies which areas. You can pause the video here and go through this picture. Blood supply. Blood supply of the face. The major artery of the face, you can easily guess it by the name, that will be the facial artery. That will be the facial artery. So facial artery. We in the lecture in the neck, the second lecture of the neck, the one where we discuss the arteries, not the second one, it was the third one. The third lecture of the neck, where we discuss the arteries, the branches of the external carotid, the branches of the subclavian. In that lecture, we discussed how does it arise from the external carotid artery, how does it reaches the lower margin of the face by coming through the submandibular fossa, and on the pathway it was giving rise in the neck, it was giving rise to the tonsillar and ascending palatine branches. In the mandibular fossa it was giving mental branches. So that discussion and that pictures we will able to find there in the lecture, in the third lecture of the neck. We will take it from here. While for discussing the arteries of the face, you must know where does it enter the face. If you sit here and clench your teeth, let me get to the 3D model. If you sit and clench your teeth, you will see this muscle that is known as the masseter muscle. The masseter muscle helps you guide the presence of the artery in front of it. So here the facial artery is entering the face just in front of the origin of the masseter muscle here. In some people, but rather I would say in a lot of people, the bone is notched here. You may able to see, feel a notch of the bone right here, and if you're not able to see the notch of the bone, palpate the notch of the bone here, you can clench your mandible, find its interior margin, find where it meets the lower margin of the mandible, and this is the point where facial artery enters the face. You can actually put your finger and palpate it right here. Okay, from here it has to move up, and for have to move up you have to remember 3 points. This point, remember this point at the anterior margin of the origin of the masseter, its junction with the inferior mandibular margin. Second point is just a centimeter or more lateral to the angle of mouth. Third is just medial to the angle of the mouth. If you remember these points, you will be able to describe whole of the pathway of the muscle. So it is running from this point to the angle of the mouth and all the way to the angle of the medial angle of the eye. So this is the facial nerve. It is running beneath the muscles coming radially. It is superficial to the buccinator, but it is deep to the levator muscles, levator labii and all of them. It is superficial to the levator anguli, but it is deep to both of them. Which branches does it give? Here, the branch that is given here, it is the mental branch, submental artery. It is going to the submental triangle. Then as it moves to the angle of the mouth, it gives rise to 2 branches, one for each lip. The one that is going to the lower lip, inferior labial artery. The one that is going to the upper lip, superior labial artery. Follow up, it will give branch to the nose. It will give branch to the side of the nose. That is called lateral nasal branch. And it ends here, terminating at the median angle of the eye. It may communicate with the artery exiting the eye that is known as dorsal nasal artery. Keep in mind the artery exiting here and the nerve exiting here have both different names. The artery that is exiting here is dorsal nasal artery. The nerve that was exiting here was infratrochlear nerve. Apart from these arteries, there is two arteries that are supplying different aspects of the face. First, this artery that is going all the way up. This one. This is called superficial temporal artery. That is called superficial temporal artery. It was the terminal branch of external carotid artery that is going to supply the superficial aspect of the temporal fossa. So it will go and it will divide into many branches: the middle branch, zygomatico-orbital branch, the frontal branch, the parietal branch, the auricular branch. There will be many branches that will be spreading out from the superficial temporal artery to supply the area around the temple. Keep in mind this artery. This is the zygomatico-orbital or branch that is going to enter the temporal fossa. We will discuss it later. And then there is this artery that is an important one. That is the one that is coming on the anterior aspect and it is running transversely across the face all the way to the front of the cheek. That is known as transverse facial artery. So this is all the discussion about the arteries of the face, and apart from it there are arteries that are exiting the orbit along with all the branches. There are arteries that are exiting the orbit along with all the branches. Those will be the same named arteries. The one that is exiting along the supraorbital will be supraorbital nerve artery. Along the supratrochlear will be the supratrochlear nerve. From the lacrimal, near the lacrimal, that will be lacrimal artery. From the two openings, zygomaticofacial and zygomaticotemporal, the same one will be there. And we are left with infraorbital artery. So the point I am trying to make it, all the nerves we discussed coming out of the different foramina of the orbit will contains the arteries by the same name. There will be only one discrepancy in the name, and that we discussed was for this artery. This nerve was named here, the nerve was named as infratrochlear nerve, but here the artery, it is named as dorsal nasal artery. So this is about it. The different branches, the supratrochlear, supraorbital, zygomatic, temporal are not shown in here, but we can see them right here. So these are all the branches, and here one important thing comes into play, that all of the arteries exiting the eye, supraorbital, supratrochlear, zygomaticofacial, zygomaticotemporal, infraorbital, and dorsal nasal, those are all ultimately branches of the ophthalmic artery. Ophthalmic artery was the branch of internal carotid artery. So there is a connection between the branches of ophthalmic artery and the branches of external carotid artery, superficial, temporal, facial, as they come to the face. So there is a connection between the two circulation, internal carotid and external carotid circulation, as it comes to the surface. So this is the neatest picture, and they have, in this particular picture, I'm leaving it for you for taking a screenshot. They have shown in blue and red the arteries that are coming from ophthalmic artery and the arteries that internal circulation, internal carotid circulation, and the arteries that are coming from external carotid artery. So this is all about the blood supply. Talking about the venous drainage, there will be the same veins: supraorbital, supratrochlear, supraorbital, zygomaticofacial, lacrimal, zygomaticotemporal, infraorbital, superficial, temporal, facial vein with all its the same tributaries, but they will have a different draining points for some of them. Let's talk about the superficial temporal. We talked about it yesterday also in the last lecture, but we'll discuss it again. The superficial temporal vein joins the maxillary vein to form the retromandibular vein. There is no external carotid vein. It forms the retromandibular vein. In a retromandibular vein, as it comes down, it is superficial temporal vein. From pterygoid plexus, they are coming the maxillary vein. They are forming the retromandibular vein. The retromandibular vein, as it comes down, it breaks. It breaks into an anterior division and it breaks into the posterior division. The anterior division is called joins the facial artery, facial vein. Posterior division joins the posterior auricular vein to form the external jugular vein. Here the thing I want to focus is these connections. You can see in the infratemporal fossa there is this pterygoid venous plexus. This pterygoid venous plexus is communicating through the retromandibular vein, through maxillary vein, but it is also communicating through the facial vein, through this vein that is known as deep facial vein. And it is connecting through foramen ovale, spinosum, lacerum to the cavernous sinus above. So all of these veins have a connection to the cavernous sinus above. Second, the arteries on the medial angle of the eye, on the lateral aspect of nose, they are connected to the eyes inside the orbit, the superior and inferior ophthalmic vein. These veins join the facial vein in front to the cavernous sinus back because they have ultimately to drain into the cavernous sinus. So you can see from this tip of the nose, this point, through the ophthalmic veins, and from the angle of the mouth, through the deep facial vein and pterygoid venous plexus, this area is ultimately joining and it area is ultimately having a potential connection with the what, with the cavernous venous sinus. So any infection that usually the blood don't follow this pathway, but if due to any reason there is a block in this way, or a due to some other reason, due to some any blockage, blood may move back to the cavernous sinus, and if the blood is infected it may move back to the sinus and it will lead to cavernous sinus thrombosis. And here is the one that we tend to pop our pimples like this, and if we press too much and the pimples pop in the inside, they will move through these veins and reach the cavernous sinus, where they will endanger the formation of the cavernous venous thrombosis. So this is known as danger area of face. You are advised uh, not to leave this area alone, not to manipulate it too much, otherwise you may drive a risk of developing cavernous sinus thrombosis. Lymphatics we have discussed in the previous lecture, but one formula I wanted to discuss right here. You just discuss the facial artery. Let me draw the facial artery. It will be from this point to the angle of the mouth to the this. So this is the facial artery, this line. So beyond the facial artery, if we start something beyond the facial artery, this area it leads to the parotid nodes, the one that is in front of the parotid gland, in front of the ear. The mastoid, the preauricular nodes and parotid nodes, the one over the cheek will be buccal nodes, and the area all the way down it will go to the submandibular nodes. And then the other area that we have to know is the four incisors, two on this side, two on this side. This area it drains into the submental node. The area that is lateral to the facial artery it drains to the parotid nodes, and the area that is between the two that is draining into the submandibular node. And this middle one area it has buccal nodes in the pathway. So this is all about the lymphatics of the face, the nodes, buccal, submental, submandibular, preauricular. So and behind the face there is this, behind, just behind the ear, there is post-auricular, retro-auricular or mastoid nodes, and in the tip there is tip of the posterior triangle there is this occipital nodes. So we are done with the face. Let's talk about scalp. Scalp is the cap of the skull. Scalp is made up of 5 layers. The 4 layers extend, it is extending from the eyebrows. When we talk about the scalp, we are talking from this eyebrow. So forehead is included both in the face and the scalp, and it is moving from the eyebrows all the way back to the edge point of insertion of the occipital belly of front occipitalis, and this is the highest knuckle line. So this is the scalp. It is made up of 5 layers. The layers are indicated the name by the artery by the first letter of each word. S, skin. It is the thickest skin of the body, hairiest skin of the body, and especially the occipital region. That region, that is the one that is having the most hair. And you may see some of the people who tend to go bald. That region is the last one to go, and in a lot of people it survives. So that region, that is called the occipital region, that is the hairiest part. Then cutaneous connective tissue, C for connective tissue. This is the dense connective tissue, and this is the part that contains most of the vessels. Most of the arteries, veins are present in this layer. Don't be fooled by the fact that the loose connective tissue is downwards and the loose connective tissue has more space. Dense connective tissue has the arteries, and that's the reason the dense connective tissue, immediately when the skin breaks, the skull bleeds profusely. The skull bleeds very badly because there is a whole anastomosing network of arteries and veins that is present in this connective tissue. And immediately below it, the level that is layer is aponeurotic layer, that is the same glia aponeurotica, the aponeurosis that was connecting the frontal belly and the occipital belly. Then there is loose connective tissue that basically gives a sliding space for the aponeurosis above. If you place your hand on the top, you can move it like this, and it is moving over this loose connective tissue. All 3 of the upper layers are moving as a unit. The lower one is moving actually, and then we are left with the periosteum of the bone of the skull, that is known as pericranium. And what happens is, when there is a cut to the third layer, that is aponeurotic layer, first the dense connective tissue has a lot of blood, and there is a lot of arteries and veins. Second, there is aponeurosis, that muscle contracts and the space is gaped widely. The A large gap is created. So that gap leads to the arteries remaining open for a long time, and you have to stitch it up to close the profuse bleeding. So what are the arteries? So this is a picture from, I think it was from Vishram Sen, to help you focus on the fact that the deep connective tissue, the dense connective tissue, the second layer contains most of the arteries, veins, and nerves. Okay, so these are all the arteries that you discussed in the face. On the midline, near the midline there was supratrochlear. On the lateral aspect, supraorbital. Then the other nerves, the other arteries that we discussed, the lacrimal, zygomaticofacial, zygomaticotemporal, they don't come all the way up, but on the lateral side, superficial temporal artery, it is a major contributor. Just behind the ear, that is posterior auricular branch of external carotid, and on the back, there is occipital nerve branch of external carotid. So these 5 arteries, they come from front to back, and they join on the surface to form a large network that supplies all of the scalp. Keep in mind, this whole network is supplying the skin. It is not supplying, rather, it is not the major supplying factor for the periosteum and the skull below. Even if a person with degloving, sometimes in our country it does happen. A lady was going into the bicycle, her dupatta got stuck in the motorbike, and degloving injury occurred. The hair were pulled, and the skin and all the layers of the scalp were pulled. The one thing that you have to first know, that the separation occurs in the fourth layer, the loose connective tissue layer, the fourth layer. And this means that the blood supply is taken with it. Blood supply is taken in the second layer. But even if that person, the arteries, they remain, the skull that remains alive, because it is major supply is from the interior aspects, the middle meningeal arteries that are supplying it. The nerves of the scalp are the same one, but a few more branches are there. There on the midline there is supratrochlear nerve. It does not extend beyond the hairline. Then on the lateral aspect, there is supratrochlear nerve, usually divided into medial and lateral divisions. It goes all the way up to the vertex. Lacrimal does not come upward, but here is the new thing. Zygomatico-temporal nerve exiting from here, temporal region. It exits up to reach the scalp. Counterpart of superficial temporal, it is known as auriculotemporal nerve. Here is the nerve that is going upwards in front of the ear, auriculotemporal nerve. On the back of the ear, there is lesser occipital nerve. This is branch of cervical plexus. Auriculotemporal is branch of mandibular division of trigeminal nerve. On the back, there are two nerves, that is greater occipital nerve a little laterally and third occipital nerve a little medially and downwards. So this is the spine of the scalp. The scalp itself does not contain any lymph nodes, but it follows the arteries. So near the midline, it will follow to the submandibular nodes. On the lateral aspect, it will follow the superior temporal, superficial temporal to reach the parotid. Behind the ear, it will follow to reach the mastoid. In the occipital region, it will follow the occipital artery to reach the occipital nodes. So this is all about the face and the scalp. Let me take a little breather here, a 2-minute break, and after that we will discuss the muscles of mastication and temporomandibular joint. Welcome back. We will now continue with the second part, that is the muscles of mastication and temporomandibular joint. So let's start with the muscles of mastication. I will prefer to go through the 3D model. Let's go there. So let's talk about the muscles of mastication. There are four muscles that we are going to discuss. These are temporalis, masseter, lateral pterygoid, and medial pterygoid. First, let's talk about the temporalis muscle. Temporalis muscle, it is originating from the fall of the temporal fossa. It is basically originating from the inferior temporal line. You can see right here. It is originating from the fascia that is covering on the top of it. We are not seeing it here, and it will go down and insert into the coronoid process of mandible. Like, see, it is inserting into the coronoid process of mandible. It is attaching on the tip. It is attaching to the coronoid fossa, and it is going back downwards into the anterior ramus down to the molar teeth. Here it will fall retromolar fossa also. Let me go back. Yes. So this is temporalis muscle. As you may have already guessed by its location, its major role is to close the mouth. It is connected to the margin, it is connected to the mandible, and it will close the mouth. So it is very simple. However, its function can be divided into two parts. If you look at the direction of the fibers, if you look at the direction of the fibers that are most interior, they're running in this direction, and the fibers that are most posterior are running in this direction. So the interior fibers that are majorly responsible for pulling the mandible upward. They are responsible for closing the jaw. The other one, the back ones that are pulling it in the backward direction, these will be responsible for pulling the jaw backward. Usually you don't need it, but if the jaw is protruded front, you need to retract it like this. Right? So this back action was done due to this, due to temporalis muscle. So this is about the temporalis bone, its origin, temporalis fossa. Its origin is shown right here. This is the temporalis fascia that is covering it. I will go into the little detail of the temporalis fascia also, and its insertion and its function. Closing of the mouth, and then we come to this muscle. This is known as masseter muscle. Masseter muscle is supplying masseter muscle is the one that is closing the jaw. It is originating from the zygomatic bone, you can see here, and it has two heads, the superficial head and the deep head. Let me show you, differentiate between the two. This is the superficial head and this is the deep head. This is the deep head. Let me go back and make this superficial head a little transparent. So this is the deep head inserting into the, this is the deep head and this is the superficial head, they're inserting into the mandible. And the point I want to make right here is the direction of the fibers. You can see the superficial head is going in this direction and the deep head is going a little in this direction. So they are making a cross, and the major function is to close the jaw. That it should be the given, and if you have to remember one thing, that is that they are closing the middle, that are closing the mouth, that are closing the jaw. However, they're also responsible for, hmm, however, they're also responsible for moving the jaw anteriorly. You can see from this direction, the jaw can be moved a little anteriorly due to this action of fibers. Like the muscle are acting going it, so its horizontal component will pull the jaw forward. So these are the functions of the masseter muscles. These are the origin of the masseter muscle. These are on the lateral aspect. So you can revise these things on this picture. In this picture, you can see the, in this picture you can see the masseter muscle, its origin, insertion. Here the insertion point is cut, deeper part, the superficial part, and here you can see that the masseter muscle is supplied by the artery from the maxillary artery and from the branch of mandibular division just through the notch, supramandibular notch. The fibers are coming to supply the muscle. We talked about the temporalis. Let's talk about the muscles that are inside. They are a little tricky. These are the pterygoid muscles. So first talk about the medial pterygoid muscle. Everyone has a different way of thinking, and I don't hope for each of the person to think the way I do. You may be thinking in better terms than me, but what I like to think is that masseter on the outside and medial pterygoid on the inside, they are like forming a burger. They are forming a sandwich. In between them there is a ramus of the mandible. So let me get to here. You can see the masseter here and this medial pterygoid medial pterygoid hair and masseter hair, they are running in the similar direction. You see, masseter, if it was not cut, it would have been running in this direction, moving to the zygomatic arch. Masseter hair and zygomatic to the back, they are both running in the similar directions, and in between them there is the ramus of the mandible. So this is one thing. So this will give rise to the fact that they will have a similar function in closing the mouth, and they will have a similar function in moving the jaw forward, in protraction of the jaw, because it is again covered to the anterior aspect. So what are its origin? Its origin is consisting of two heads, superficial head and deep head. Both of heads are arising from the two aspects of this bone, the lateral pterygoid plate, the part of the sphenoid bone, the lateral pterygoid plate. So this medial head, it's coming from the medial aspect. The lateral head is coming not technically from the lateral aspect, but in front of it from the here. If you have remember, there was the this pyramidal process. There was this pyramidal process of the palatine bone. So it is basically originating from some of it. It is originating from the pterygoid plate, but it is originating from the pyramidal process of palatine bone and maxilla, and these two, they come down and they get inserted on the angle of the mandible from the inner aspect. So this is medial pterygoid plate. Lateral pterygoid, medial pterygoid muscle, lateral pterygoid muscle. It has again two heads. This is the lateral pterygoid muscle, the one that is originating from the lateral aspect of the lateral pterygoid. The second, it is originating from the inferior aspect of greater wing of sphenoid. Here is the infratemporal crest we discussed in the osteology of the skull. This is the infratemporal crest. Here you will move to temporal fossa, and here you will move to infratemporal fossa. So actually we are talking about the muscles of the infratemporal fossa. So here it has two heads, the one originating from the inferior aspect of the sphenoid bone, of the greater wing of sphenoid, and the other one that is originating from the lateral aspect of lateral pterygoid plate. And where they are inserting? They are inserting back into this temporomandibular joint. Let me show this particular fact on the pictures. Let me summarize my things right there. So we have talked about temporalis muscle, its origin insertion, not repeating again. Here we talked about the in the 3D model we discussed the mm, pterygoid muscles, the medial pterygoid muscle, the superficial head and deep head, the lateral pterygoid muscle, the infratemporal, and the part that is rising from the lateral aspect of the lateral pterygoid plate. It is inserting by merging with the articular disc of temporomandibular joint. It is technically inserting into temporomandibular joint. So it is basically major role. It's to pull the jaw forward, protraction of the jaw. So this is about it. Um, One thing that was to be discussed, that can be discussed, was the relation here. The medial masseter muscle, the medial pterygoid muscle, it runs. Let me go to the 3D model. The medial pterygoid muscle, it runs lateral to the sphenomandibular ligament. This ligament will be discussed again when we talk about the temporomandibular joint. It is coming from the spine of sphenoid, just behind the foramen spinosum, and it is getting inserted into the mandible just above the lingula. Here is the lingula and mandibular foramen. The pterygoid muscles are medial to it, are deep to it. The lateral pterygoid muscle is coming lateral to it, and medial pterygoid muscle is going lateral to it. That will come in the little handy as we move along. So this is a summary slide. The table is taken from the Snell's anatomy by regions, and it's taken from Snell anatomy by regions, and here is the pictures from Gray's anatomy. You may pause the slide here. Oh, sorry for that. So this is a summary slide, and it is showing the origin insertion, and all of these are supplied by mandibular division of trigeminal nerve, and these they're showing the origin insertion and the nerve supply and the functions. You can pause the slide here and revise it for yourself. The table is from Snell's clinical anatomy, and this image is from the Gray's Atlas of Anatomy. Let's move to the next topic, that is temporomandibular joint. Temporomandibular joint is the one between these two bones, temporal bone and the mandibular bone. The articular surface is basically the condylar process, the head of the mandible, and the mandibular fossa of the temporal bone. So these two bones are making the temporomandibular joint. It is an atypical joint, and it is a synovial joint. And with synovial joint, you will read two additional words. You will read atypical and you will read complex joint. It is called complex joint because it has a disc in it. Any joint with a disc or a meniscus inside its cavity, it is called a complex joint. It is called atypical joint because the articulating surfaces over the mandibular fossa and the head of the mandible, the condylar process, those are not covered with hyaline cartilage. These are covered with fibrocartilage, and due to this region, not hyaline cartilage, due to this region, these are called an atypical synovial joint. Okay, let's talk about the ligaments. What things are giving it its stability? First, there is a ligament on the lateral aspect that runs from front to back, from the zygomatic arch to the back of the mandible. That is known as lateral ligament, lateral temporomandibular ligament. As you can see from the direction of the fibers, it won't allow the mandible to go to the back. Then there is sphenomandibular ligament. We just saw in the 3D model. It is coming from the spine of sphenoid, and it is inserting into the lingula of the mandible, and it is sphenomandibular ligament. And we are left with the stylomandibular ligament. It is not these two ligaments, the sphenomandibular and the sphenomandibular, they are not directly linked to the mandible itself. They are away from them, but they ultimately keep the mandible in its place. So this is the stylomandibular ligament arising from styloid process and running to the mandible near the inside of the angle of the mandible. So these are the ligaments, and it has, then the last thing that it has, it is the articular disc. In front, it is attached to the insertion of the lateral pterygoid muscle. Behind and laterally, it is attached to the capsule, and behind it is also attached to the mandible and even the temporal bone. Here the tendon is split to be attached here and here. So this is about the functions, the structures that are forming it. Let's talk about the movements. The movements, there are three possible set of movements. First, elevation, depression. Depression, elevation. Depression, elevation, going down of the jaw and coming up of the jaw. Then there is protraction and retraction. Moving the jaw front, moving the jaw back. This is protraction and retraction. And then there is side to side movement. This is basically gliding type of movement. So these three movements help us in chew. Let's discuss which muscles are creating what movements. Closing of the jaw, elevation. There were four mastication muscles, three of them. Temporalis muscle, it was coming from here down to the mandible, and medial and pterygoid and the masseter muscle, they are moving the jaw up. So these three muscles are moving the jaw up. Depression, opening of the jaw. Normally speaking, It does not require any additional set of muscles. It just you let go of the muscles that are present, and jaw will drop. Gravity will do its work. However, when you have to work against a pressure, then you need to get the muscles below the mandible active. So the supraoid group of muscles that included the digastric, the genioid, and the mylohyoid, they get active and they reduce the distance between the jaw and the mandible, jaw and the hyoid bone, and they depress the jaw forcefully. So this is about elevation and depression. Then there's protraction and retraction. Protraction and retraction, we talked about the direction of fibers of masseter and medial pterygoid. They will be having a role, and in addition to that, the major muscle that will be doing it, that will be lateral pterygoid muscle. That will be lateral pterygoid muscle. So lateral pterygoid will be the chief one, and medial pterygoid and masseter will have a helping hand in moving the jaw into front. And then we are left with retraction. Taking it back, retraction will be done by the horizontally running fibers of the temporalis muscle and deep part of masseter. You saw that masseter's fibers were running in two different directions. So the fiber of the superficial fiber was suitable for protraction, but deep fibers were running in this direction, helpful in retraction. And protraction, retraction, and there will be genioid and the same muscle, genioid and digastric, because the hyoid bone was actually behind it, so it is pulling the mandible towards that. So temporomandibular joint is moves like this, and we are left with side to side movements. These movements are done by the pterygoid muscles, medial pterygoid and lateral pterygoid. When one muscle contracts, if lateral pterygoid left-sided muscle contract, they will move the jaw to the right side. They were like this. They pulled the jaw towards themselves, so they pull the jaw inside. The left side muscle will contract. They pull the jaw towards themselves, and jaw will go like this. And then this will contract, and this is how we chew. We go like this. We depress and side to side movement, and we go on chewing thing. So this is about the temporomandibular joint, and let's discuss the nerves. The Hilton's law, the nerves that is supplying this. Let's not discuss the Hilton's law right now. The nerve that is supplying this joint is the auriculotemporal nerve. It was coming from back of the mandible, moving from here and moving up like this. So this was auriculotemporal nerve that is supplying the temporomandibular joint in addition to the other things that it is supplying. And we talk about the dislocation of temporomandibular joint. Normally, the temporomandibular joint is very stable in the closed space. The closed space, this is the closed space, closed point. The mandibular fossa is fitting the mandibular head, and when the mouth is open, let's see, when the mandibular head will come right here on the top, and it will go like this. Okay, now in the normal position in the closed mouth, the head was snugly fitted into this fossa, and even if the lateral pterygoid muscle tried to pull it forward, it would have been blocked by this protrusion of the bone, the articular tubercle, because it was originally there. But when you open the mouth, when the jaw drops, the head comes to the tip of the articular tubercle. Now it is vulnerable. It does not have anything stopping it in front of it. At this particular point, when you have opened your mouth very big and the lateral pterygoid muscle goes to spasm, or there is a blow from the back, then what happens is the jaw moves front. The jaw moves to front. It moves all the way to here with the coronary process right here. See, it will move to this point, and when it move to this point, it is stuck now. When it tries to go back, the same thing, the same articular process that was protecting it from going outside, it will be inhibiting it from going to its normal location. So the jaw will get stuck. That is called temporomandibular joint dislocation. Some of you may have experienced this effect that when you open the jaw clicks. It is basically mandibular going front and back of the articular tubercle, and jaw may get, some people it does get stuck when you take a very big yawn and the mandible gets stuck there. And what you have to do is you have to put your thumbs on the teeth, you have to push it down, you have to push it down that it comes down, it can go over the articular process and it can go back to the fossa in its normal position. And sometimes the muscle spasm is stopping it too much that you have to give the person anesthesia before pushing it down and pushing it back. So this is what temporomandibular joint dislocation. This is a summary slide from the last anatomy, and all of the muscles, rules, and the movements is summarized here. You can take a screenshot. So I will stop my lecture here. I will stop the live stream here, and I will continue to keep on recording, and you will find the recorded lecture in the album. So now from this point onwards, I have to discuss the temporal fascia, the parotid region, the infratemporal fossa, the temporal fossa, and the pterygopalatine fossa. These are the topics that I will be discussing from this point. I will be uploading shortly within few hours, inshallah. You can follow this in the album of the head and neck, and I'm getting off the live feed now. Thank you so much for being here, being live. If you have any questions, suggestions, feedback, please do contact us, and don't forget to support us. Thank you so much. Inshallah, see you in the next video.